it's not like we're making a part that was milled and we're trying to show someone, if you make it with additive, it's lighter and cost effective, and here's the dollars and cents. If you make 1 million of these, it'll be more efficient and lighter, save on jet fuel. We don't have to make those arguments. Well, I'll talk about myself a little bit first. So I was doing research at the NIH during medical school, and I moved to the National Library of Medicine Office of High Performance Computing. And there I met Terry Yu and David Chen, who were doing some 3D printing with Bethesda Navy. And they said, do you want to do this project on spine, pedicle screw, trajectory planning using 3D printing, of which I had never heard of any of those things. So my first exposure was in 1999. I then started a radiology residency, or the training after medical school, at the Mayo Clinic in 2002. And in 2004, we had a set of conjoined twins that the surgeon, who had all the radiology and all the medical illustrations that he needed, but he wanted a physical surrogate of the twins' lungs. So that was really one of the first clinical cases done. There have been people using FDM to do a few things before then. But really, that was one of the first times the Department of Engineering at that time took that on and printed a surrogate of the patient's liver and chest wall. From that time on, we did a couple more conjoined twins, and then one of the spine surgeons saw the spine along the conjoined twins' chest cavity and said, well, I do these congenital scoliosis kids. Could you print me some spines? In the first few years, we were just doing 20 spines, 10 spines. Went to 30, then 40, then other people's spines with tumors, and then other surgeons said, hey, I do these other things, can you make me X? And eventually we had to form our own clinical unit, because the Department of Engineering, which is an amazing facility at Mayo Clinic, essentially works on longer term projects and works on research projects, or works on things that you're prototyping, maybe a medical device or something that you need over a series of time, where this was real-time manufacturing for patients going to the OR. So the Department of Radiology, which I work in, said, well, let's form our own unit, because 90% of all patients go through the Department of Radiology. And then we hired our first engineer, Amy Alexander, who still works in the Department of Engineering. And then since that time, we've really grown to where we now have about 18 full-time employees, about 10,000 square feet of manufacturing space, right above the operating room. Yeah, so total, we've got about 46 printers, if you count Department of Engineering. And we've got everything from, at Mayo Clinic, we've got everything from small Formlabs polymer printers through a number of commercial industrial FDM machines from Stratasys, prosumer FDMs like Ultimakers. We've got Stratasys photopolymers and the J850, and we've got J55s running. We've got HP 580s doing full color nylon. We've got EOS Formigas doing nylon 11 all white. And so we've got most of the ASTM standards, 6 of the 7 at Mayo Clinic, and they're all for different purposes. Some we're doing biocompatible polymers, some we're doing nylon 11. We're not doing implants with titanium yet, and then we're bringing in PEEK this year. So that'll be FDM with PEEK. So most of what we focus for is taking radiologic images, making patient-specific 3D models of their anatomy. Not everything in the scan, but what's critical, maybe the arteries, veins, tumor, the way the tumor is moved, the normal structures around, and building sterilizable cutting guides that screw onto the bone that then guide a surgeon's saw along a path so that you get a negative margin, like a 2 centimeter negative margin around the tumor, but then also it'll either fit a custom implant, or we need to take a bone from one part of your body and fill that gap, or take a bone from the bone bank, or do a complete elbow transfer, things like that. So we've been doing that within a regulatory infrastructure, both that the point of care manufacturing facilities feel comfortable with, the FDA has released guidance documents for, which risk stratified. So diagnostic models are one risk, right? Diagnostic models that are using maybe mirror imaging one part of the skull to the other and then building custom appliances off that, another risk. 3D printed sterilizable cutting guides that are actually going to have to fit on the body and are made to cut next to a tumor. That's the next level of risk. Once you get to where you're manufacturing something that's going to stay inside the body for essentially the rest of the patient's life, That's the highest level risk. And even in that risk category, you have things like cranial plates that might not bear any weight, all the way up to something like a knee implant or a hip implant, something that's going to custom that has to not only fill a space, but also has to function like a normal part of the body. So each one of those, the risk level keeps going up. So most hospital systems will never have the infrastructure to do implants, to be quite honest, or they'll have a third-party manufacturer live at the site, like at Hospital for Special Surgery they do, but the manufacturer lives there doing manufacturing as that company. And then you have to have a need for a lot of customs. So if you're doing a lot of custom implants, the cost of custom implants is really high. So if you see these great cases where someone took a large part of the pelvis apart, built a metal printed custom implant, that can be $50,000 to $80,000 just for that piece of metal. So it's incredibly expensive. It's incredibly long time to get that implant. So being able to do some of that work in-house, not the large hip implants, companies like Stryker and that do that for us, or Dupuis or others, but doing a truly customizable thing that we think we do a lot of, and we think that we can narrow the lead time and the cost down and still do an excellent job of, then that's the kind of stuff we're going to go after. Most of what we do is preoperative surgical planning. So about 10 to 15%, about 5 to 15% of the time, the surgeon will change their approach based on the model. Because you have to remember, people think like, oh, every doctor understands CT and MRI imaging. That's not true. So radiologists, the subspecialist doctors that do 5 years of training plus maybe 1 or 2 more years of fellowship after medical school, just to be able to look at the images and say what's wrong with you. And then if you take it the next step further and say, not just is there a tumor, but where is the exact centimeter margin of a tumor, and then how do you get 2 centimeters out there? Yeah. People can't do that aren't radiologists, right? Or maybe a tumor surgeon for their tumor, but then they can't work in the chest or somewhere else. That part is really subspecialized to radiologists. Allowing a surgeon to understand those images, so that modern imaging produces a ton of images. So if you get a CT scan, when I was training, maybe it'd be 300 images, 5 millimeters thick, all the way through the body. Now we're getting 13,500 images, 0.6 millimeter slices for every patient. Sometimes we're getting 13,000 CT, 5,000 MRI, 3,000 PET images, and the surgeon has to do all these mental gymnastics to make that three-dimensional model. And what we do is we just simplify it and do all that work and then manufacture it and then build custom appliance guided surgery. But to allow the surgeon to understand what he has to do to take these complex tumors out and reconstruct normal function or normal appearance for the face, those guidance tools are incredibly beneficial. And I don't want to make it seem like it's low risk, because if you were to make the tumor the wrong size, if you were to not outline the size of the tumor correctly, and you put the saw through a tumor like in the pelvis or in the long bone, the patient is 100% recurrence rate of that tumor, and you've just doomed them to a life of metastasis or local recurrence. So it's still high stakes, it's just lower risk in leaving something in the body for the rest of their life. Well, one of the things I learned at places like SME is it's a common problem across multiple industries. So I think it's gotten better over the years because people now get additive manufacturing experience in university levels. But like when I started going around to Fords or BMWs or defense industry or aerospace, you'd say, how do you keep all these printers running? They'd say, oh, we had to train people. Those guys, see, they are experts. They do the work for us. So I think having well-trained workforce to run the machines as like a machinist for additive, but also having designed for additive, those things are unique skills that aren't germane to medicine. In medicine, we have even more uniqueness in that they have to understand CT and MRI. And if you got a biomedical engineering degree, you might get a little anatomy, you might know what imaging is, but we need them to know what CT and MRI is at a deeper level. Then we need to know what anatomy is at a deeper level, like physicians. Then we need them to know pathologies, like tumors, and speak the surgeon's language. And then they have to also know design for engineering. And then they have to know medical CAD. And then they have to know the additive manufacturing technologies and which one is right. And then there's quality control, regulatory, all of these things that they have to know, because we're 18 people, yes, but each person is doing multiple roles. We don't have just like, oh, those 2 people do quality engineering and these 2 people do design for additive and these people just do the machines. Like, we do have people that are called healthcare technology management, but we had to train them too. How do you not just fix CT scanners and X-ray machines. How do you run additive manufacturing equipment? So we don't have a school per se, but it is a steep learning curve for everything I just said. And we take people out of university level that might have like 1 or 2 or 3 of those things. Like I know additive, I know design for engineering, but I don't know anything about CT or, well, that's great. I can teach you that because I know CT, MRI, anatomy, pathology, surgery. I can teach you that. But they come with like 1 or 2 or 3 things, and then we train them. And then unfortunately they get pilfered too, because then they're a really attractive employee for somebody else who needs that, right? So getting medical additive manufacturing employees, there's not a super proficient pipeline. You have to make these people, these unicorns, and then they have to buy into the mission of, I like what I do on a daily basis that directly impacts the suffering of another human being, that does it for me. So I'm willing to work hard, maybe stay late. I mean, it's healthcare. It's different than your average engineering job. And lucky for us, our engineers really buy into that methodology of helping ease the suffering of another person. And they can go see them on the floor. They can go down to the OR. They're in the hospital. They're not remote workers. They're there because the surgeons come up anytime they're free and walk in and out of the place. I tell our team the same thing, is that we could write that story every week, because every week there's something just unbelievable that happens, because Mayo Clinic's a destination medical center, so people come with complex problems and we bring manufacturing to bear on those complex problems. And there are several patients that stand out over the years because the patients will also come tour the lab. So we had a young patient who had a sarcoma in the testicle, in the groin area, and they had to remove it. He was like, under 10 years old. And then he had cancer had spread, metastasis along his what's called retroperitoneum, or along the area around the aorta, big blood vessel in your spine. And the surgeons asked us, can you make us a model so that we have one chance to clear this all out, and then he'll get radiation. But we've got one chance to make him tumor-free and have a real chance at any long-term survival or 5-10-year survival. So we made that model for them. The surgeons came upstairs and they said, it worked great. We were able to clean it out. Here's the pictures. They always take pictures for us, the model and the patient. And then the patient came with his mom and dad, and we give him the full tour and show them all the printers, let them play with the stuff, after they've recovered a little bit. And there's meaningful stories. Last week, there was a patient with a massive hole in his trachea. Had failed every other therapy. One of our engineers made a custom 3D printed mold for a special type of biocompatible material called MedPore that they molded in the OR, hot water baths, cold water baths, 3D printed custom mold just for his trachea. That patient did amazingly well. And he made it through the surgery and now has an airway that's functional, So every week we're doing something like that. A large pelvic tumor that you want to preserve. You want to say, yeah, we could certainly do what's called an external hemipelvectomy and take from this side of the leg and take the whole leg off, and you have a whole leg prosthesis. But is there a way that we can do a more bespoke surgery? Get the tumor out, but leave the nerves intact to the leg? Or we even had one of our own employees who had a really bad tumor in her distal femur down at the knee, and they could just do an above-the-knee amputation. That would be the standard of care. But they were allowed to think and say, what if we make a guide for the tumor, and then the guide will fit on the leg, and then we'll cut out the tumor, and then we'll make a guide for the bone bank bones. And then we'll fit that bone bank inside of there, and we'll take her leg bone and put it inside the cadaver bone, and then tie that blood vessel to her blood vessels and plate it all together. And then, 6 months of recovery, 8 months of recovery, and she still has a leg and is walking around the hospital every day. It's a dramatically different outcome because the technology is present in the hospital. The surgeons are allowed to think like this, and they come to us, and what we bring to bear on it is the technology. And we don't say, what's your budget? How much do you have to pay us? It's a service to every one of our surgeons and clinicians that just has to press an order button, and we're available for the patients at Mayo Clinic. And because of the needs of that patient, she got a dramatically better outcome than if we just did the traditional, let's do an above-the-knee amputation. We have a lot of room to grow. And someone says, well, how do you get customers? How do you convince people? And there was convincing to happen, but our surgeons have, it's not like we're making a part that was milled and we're trying to show someone, if you make it with additive, it's lighter and cost effective, and here's the dollars and cents. If you make 1 million of these, it'll be more efficient and lighter, save on jet fuel. We don't have to make those arguments. We have to say, will the patient be better treated if we employ manufacturing techniques, if we do things like guided osteotomies, if we do things like guided resections, if we custom bend plates for the chest, if we build custom appliances that allow heart transplant patients to, like, our return on investment is the needs of the patient. So our value equation is different because, yes, we save time in the OR. Yes, our OR is $100 a minute. So every 90 minutes we save $9,000. There is a money equation why this works, but the reason it exists inside the hospital is because of the needs of the patient that come to Mayo Clinic, which is what fuels everything at Mayo Clinic, is just focused on the needs of the patient. So we have room to grow into implants. We have room to grow into what are called medical device production systems, where the system is FDA cleared and I don't have to get an FDA clearance for every end implant we make. There's regulatory growth, there's IT growth, there's quality growth, there's quality management growth. There's growth in this whole industry because one of the things that really holds this industry back, in my appearance, for me, is there's not a lot of reliability. Like, we still have inter-printer reliability problems. We still have uptime problems. We still have brand new systems that are down all the time. And the vendors, you know, they're as good as they are, but there's no, what other printer am I going to go to? Like, this printer does it. Right, and I've learned that. I've learned that, not to be negative, but I've learned that from aerospace and automotive and all these other people. Like, if you want to put a part on the Ford Mustang, it has to work all the time. You know, supply chain is critical. For us, if we have to go to the OR on Monday and there's a job we put on Friday, that weekend, we don't have another weekend. We're not making boat props. They're going to the OR on Monday. So, you know, the room to grow for us by application is large, especially when it comes to implants and custom applications, because we have more patients coming to Mayo Clinic. The room to grow in the industry is also large because as printer companies get better, as inter-printer reliability gets better, as the ability to actually do this in a way that has Six Sigma levels of reliability all the time, you know, then we can start, like, not focusing as much on the infrastructure we need to keep everything running and focus on the applications and automating it. Like in imaging, we have a lot of AI running in the machines. So the MRI machines, the CT machines, they have AI running inside, looking at errors, auto-correcting errors, doing things so we don't even see errors in the imaging, right? Like, it would be nice to see that. Like, where is the AI in the machine that it's detecting that there's a problem, fixing the problem, automating the software, instead of just coming in on a Monday and it's blinking.
Yeah.
Right? So AI inside of machinery is happening in other areas of medicine, particularly in imaging, to keep us from ever seeing the errors, you know, and making things faster, more reliable. So it'd be great to see that start to pilfer into my additive world. We're using AI for going from imaging to model to guide. So how do we do that faster? So what used to take 4 hours, maybe an entire spine with metal and hand tracing.
That is awesome.
Now we're working with companies. We got about 8 AI algorithms running within our own space. We've got about 36 running in our department at any given time. So that's happening. And the AI to automatic build medical devices, happening, slower, but happening. AI to build medical devices that are automatically correcting deformities without having the surgeon interfere with it. That's also happening. So there's a lot of places we're using AI on the front end. What I guess what I'm saying is on the printer part and the post-processing part, more automation, better reliability. That would be great for us. The first thing I ever 3D printed was a pedicle screw trajectory guide. 1999, Bethesda Navy. Terry Yu and Dave Chen at the Office of High Performance Computing in the National Library of Medicine put me on this project. I was a medical student. I had no idea anything about it, and the first thing I ever printed was something medical that we do today. Pedicle screw trajectory guides, to which there's companies that offer it now. But yeah, it was an eye-opener, and it was exposure. Giving me exposure to the technology and seeing how the technology can be used in medicine is really the impetus of what I do now.